Welcome to the deep dive. Today we're really getting stuck into a core topic for your ophthalmology revision and definitely for the MSRA. Squint, or as it's technically known, strabismus.
Exactly.
Think of this as us pulling out all the absolutely essential info from the notes, helping you revise efficiently.
Yeah, we're focusing right in. Squint, basically, in the UK definition, it's that misalignment, One eye points straight, the other one might turn in, out, up, or down.
Simple definition, but like you said, loads underneath it.
Definitely.
So our mission today is a proper but, manageable look at squint. We'll cover the definition, the causes, who's more likely to get it, how it actually happens pathologically.
And how to tell it apart from other things, how common it is, what you actually see clinically.
Right, plus the diagnosis, treatments, what the outlook is, and any potential problems down the line. We'll try and throw in some memory tips too, make it stick.
Sounds good.
Okay, so let's start with pinning down that definition a bit more. You mentioned misalignment.
Right. So visual axis misalignment. But the first big split you need to get is between a manifest and latent squint. Manifest, that's heterotropia. You can see it when both eyes are open. It's, manifest, obvious.
Okay.
Latent, that's heterophoria. It's more of a tendency. The misalignment only really shows up if you cover one eye, break that fusion.
Ah, okay, so one's visible, one's sort of hidden until you look for it.
Exactly. Think tropia, always there. Phoria, a potential force hidden.
That helps. Now, are there different flavors of squint? Different types?
Oh, absolutely. It's not just one thing. You've got concomitant squint. That means the angle of the squint, the deviation, stays pretty much the same whichever way the person looks, often down to just a muscle imbalance.
Right.
Frequently, that's a convergent one, an inward turn. Then there's paralytic squints. Here, the angle changes depending on the direction of gaze. That's because a specific muscle, or the nerve controlling it, isn't working properly.
Paralysis makes sense.
And directionally remember ASO for inward turning, esotropia. That includes accommodative esotropia linked to focusing effort, and exo for outward turning, exotropia. Sometimes linked to convergence insufficiency, difficulty turning the eyes in for close work.
ASO in, XO out.
Oh, yeah.
Got it. What about up and down?
Yep, vertical squints. Hypertropia means one eye is higher. Hypertropia means one eye is lower. Often points towards an issue with the superior oblique muscle, maybe a paresis.
Okay, that's a lot of categories already. Any other ways we classify them?
Yeah, we do. We think about when it started congenital, so present from birth or very early, versus acquired, developing later. Which eye is affected right, left, or it might alternate between them. Importantly, it's usually not both eyes turning in different directions at once.
Right.
Is it there all the time, permanent, or does it come and go, intermittent? We mentioned concomitant, which is non-paralytic, versus incomitant, which is paralytic, the angle changes.
Yeah.
You might hear primary, secondary, consecutive too, depending on context, like previous surgery. And there are specific types like infantile strabismus, early onset, without much refractive error, or even situational squints that pop up with certain activities. It sounds like a lot, but each term tells you something useful.
It's like building up a detailed picture. So moving on to the why, the etiology. What actually causes squints?
Well, that's often the million-dollar question, the precise cause. It's frequently unknown, idiopathic, but we think it often involves subtle issues with the eye muscles themselves, maybe how they're attached or their structure, or it could be the complex brain control, the coordination of those muscles isn't quite right.
So muscles or brain control?
Yeah, and there's definitely a genetic link sometimes.
Yeah.
Plus, it can be associated with other underlying conditions, especially neurological ones.
Right, so multiple factors often play a role, which leads us nicely to risk factors. Who's more likely to develop it?
Top of the list, as I mentioned, is family history. If squint runs in the family, the risk goes up.
Makes sense.
Certain medical conditions are big risk factors too, particularly things affecting the brain like cerebral palsy. Prematurity is another key one. The visual system is still developing. And also, existing eye problems like childhood cataracts or retinopathy of prematurity can disrupt alignment.
Okay, family history, brain conditions, being born early, or other eye issues. Got it. Now let's dig into the mechanics, the pathophysiology. What's actually going wrong?
So fundamentally, it's an imbalance in the pull of those 6 extraocular muscles that move each eye.
Okay.
This imbalance could be because a muscle is genuinely weak or maybe too tight, or it could be a problem higher up in the brain's control system that's meant to orchestrate them all working together.
And is it different in adults?
It can be, yes. In adults, new onset squint might be due to things like a stroke affecting the nerves or thyroid eye disease. Graves' disease is a classic one, or even trauma to the eye area. And remember that difference. Non-paralytic, often developmental, maybe muscle length issues from early on, versus paralytic, which is more about nerve damage or muscle damage causing restricted movement. That's a key distinction.
Yeah, that child versus adult onset and the underlying mechanism seems vital. Now, if you see eyes that look misaligned, how do you know it's definitely squint? What are the differentials?
Good question. It's really important not to jump to conclusions. The main look-alike is pseudostrabismus, or false squint.
Pseudo meaning false.
Exactly. You often see this in infants. They might have a wide, flat nasal bridge or prominent skin folds near the inner eye epicanthal folds. It just looks like their eyes are crossed, especially when they look sideways. But the actual alignment is fine. You check the corneal reflections, and they're symmetrical.
Ah, okay, so the facial structure creates an illusion.
Precisely. Another one to differentiate is convergence insufficiency. That's specifically about difficulty turning the eyes inwards together for close tasks. It's an eye coordination issue, but not usually a constant misalignment in all directions like a typical squint.
Got it. So don't just trust the first glance. How common is actual squint in the UK? What's the epidemiology like?
It's reasonably common. Figures suggest somewhere between 2% and 5% of the UK population have some form of squint.
That's quite a few people.
It is. And most cases start in childhood, usually diagnosed before age 6. It's worth remembering, though, that tiny babies often have eyes that wander a bit transient misalignments. That's normal as their control develops, and it usually settles down in the first few months.
Right. Don't panic with newborns necessarily.
No. But significant squint affects about 5% of 5-year-olds. It drops a bit in young adults, maybe 3% in the 13-24 age group. Interestingly, there are some population differences, too. Esotropia, the inward turn, seems more common in Caucasian populations.
Oh, interesting.
Whereas exotropia, the outward turn, is seen a bit more in some non-white populations. And intermittent exotropia, where it just drifts out sometimes, is actually more common than a constant outward turn.
Okay.
And that family link we mentioned, it's quite strong. Around 30% of people with squint have a relative with it, often the same type, too.
That 30% figure is quite striking. So what are the things you'd actually see, the clinical features?
Well, the most obvious sign is the misalignment itself, isn't it? One eye looking somewhere different.
Yeah?
In adults who develop it later, they often complain of diplopia, double vision, because their brain can't easily suppress the second image. Children, though, their brains are more plastic.
They suppress it.
Often, yes. So they might not complain of double vision, but you might notice poor depth perception, clumsiness maybe. Another classic sign, especially in kids, is an abnormal head posture. Tilting their head or lifting their chin, trying to use both eyes together.
The compensatory head posture.
Exactly. Parents are often the first to spot something isn't right. Or maybe the child closes one eye intermittently, particularly in bright sunshine. That can be a sign of intermittent exotropia.
And what about how they present differently, say, when they come into clinic? Kids versus adults.
Good point. With children, it's often parental concern that brings them in. You're listening for that history. Eyes turning, head tilting, maybe closing one eye. School screening picks up quite a few cases, too. You always ask about family history, prematurity, any tricky neonatal periods like jaundice or infection.
Right. And adults.
Adults are more likely to come in because of symptoms. Diplopia is a big one, or asthenopia, that general eye strain, discomfort, headaches, especially after reading. Don't underestimate the psychosocial side either. Adults might feel self-conscious, find social interactions difficult.
Yeah, that makes sense.
During the examination, you really need to pin down, is it constant, intermittent, getting worse? Look closely. Use those light reflex tests, like the Bruckner. Check visual acuity in each eye separately. Absolutely vital for picking up amblyopia. Ophthalmoscopy to rule out underlying eye disease. Hirschberg's test helps estimate the angle.
That's the light reflection one.
Yeah, where the light reflects on the cornea. Look for facial asymmetry, proptosis. And then the cover tests, cover-on-cover, alternate cover, they're key for confirming the squint and seeing how the eyes move. Always look for other eye or systemic issues.
And if the vision's down in one eye?
Investigate. Could be amblyopia, needs urgent attention. Referral pathways are pretty clear. Any constant or worsening squint in a baby needs an urgent ophthalmology referral. Older kids with suspected squint, get them to the eye clinic promptly for assessment and to prevent that amblyopia setting in.
Okay, that's a thorough clinical picture. What about specific investigations beyond that exam?
Well, The comprehensive eye exam is the main investigation, really. Assessing alignment, acuity, movements, that's
Yeah.
core. The corneal light reflection test, like Hirschberg's, is a great screening tool. Shine a light from 30 centimeters. Are the reflections centered in both pupils? Symmetrical means likely aligned.
Simple check.
Yeah. But the cover test, that's really the gold standard for detection and characterizing the squint.
Yeah.
Get the patient to fixate on something, cover one eye, watch the uncovered eye. Does it move to take up fixation? Then uncover and watch the eye you just covered. Repeat on the other side. The alternate cover test helps reveal the total deviation.
Okay, cover test is key.
Definitely. And then ideally an orthoptic assessment. Orthoptists are the specialists here. They do detailed visual acuity, sophisticated tests of binocular function, and precisely measure the type and angle of the squint.
Right, the specialist assessment.
Yeah.
So once it's diagnosed and characterized, what's the plan? How is squint managed?
Management really varies. Depends on the cause, how severe it is, the patient's age, how much it's affecting their vision in life. But the main goals are usually get the eyes aligned, get the vision as good as possible in both eyes, and try to restore binocular vision if possible.
And early treatment is important.
Crucial, especially in kids under about 8, to prevent or treat amblyopia and give the visual system the best chance to develop normally. First step is usually referral to secondary care, ophthalmology, or orthoptics.
Okay.
If there's amblyopia in a young child, patching the good eye is common. Forces the brain to use the weaker eye. Sometimes atropine drops are used in the good eye to blur it instead.
Right, patching or drops for lazy eye.
Yep. And often the very first step is correcting any refractive error. Glasses, especially important in accommodative esotropia. For kids, plastic lenses make sure the frames fit well.
Glasses first makes sense.
Sometimes prisms can be added to the glasses. They bend the light to help align the images for the brain. But tell patients it can take time to adapt to new glasses, maybe up to 18 weeks even.
Good point on managing expectations. What if glasses and patching aren't enough?
Then surgery might be considered, especially for larger angle squints or ones that don't respond. Surgery involves adjusting the eye muscles, either recession, moving a muscle back to weaken its pull, or resection, shortening a muscle to strengthen its pull.
Adjusting the muscles.
Exactly. Sometimes surgeons use adjustable sutures so they can fine-tune the alignment a day or so after the operation if needed. But it's not unusual for someone to need more than one operation over their lifetime. Maybe 2 or 3 times isn't uncommon.
Okay. Are there different surgical approaches for, say, inward versus outward turns?
Yeah, there can be nuances. For infantile esotropia, that early onset inward turn surgery is often done quite early to try and get alignment and allow some binocular development. There's some research into using botulinum toxin injections, Botox into muscles for certain squints or meiotic drops, but maybe needs more evidence for widespread use.
And for exotropia, the outward turn.
For intermittent exotropia, treatment often depends on how often it happens, cosmetic concerns, or if it's causing symptoms like eye strain. If surgery is needed, it's often ideally done between ages 5 and 8, especially if vision is affected. But milder cases might just need exercises to improve convergence, maybe avoid surgery altogether.
Exercises can help sometimes then.
For some types, particularly convergence insufficiency or mild intermittent exotropia, yes, orthoptic exercises can be beneficial.
So with all these options, what's the general outlook? The prognosis?
Generally, it's pretty positive, but it really depends on the underlying cause, how early it started, and crucially, how quickly and effectively it was treated.
Right.
But the good news is, for most people, treatment can lead to significant improvements in eye alignment and often in visual function, too. Achieving good alignment in vision is definitely possible.
That's encouraging. But are there potential downsides, complications, either from the squint itself or the treatment?
Yes, definitely things to be aware of. If squint is left untreated, especially in childhood, the main risks are impaired binocular vision, so poor depth perception and amblyopia that permanent reduction in vision in one eye. And don't forget the psychological impact, self-consciousness, social difficulties.
Yeah, the non-visual aspect.
Absolutely. Surgery, while generally safe, does have risks. You might get an over or under correction, meaning further surgery is needed.
Yeah.
Sometimes other subtle eye movement problems can develop after surgery, like inferior oblique overactivity or something called dissociated vertical deviation, which might also need intervention.
Okay, surgical risks.
And just the broader impact living with a visible squint can affect quality of life, potentially increase risk of mental health issues, and have social consequences, maybe even impacting things like job interviews.
So it really highlights why early detection and management are so important, doesn't it? Not just for the eyes themselves.
Exactly.
Okay, so to wrap up the key points for revision. Squint, or strabismus, is that eye misalignment. Remember the types manifest latent, concomitant paralytic, astoexal hyperhypo. And remember that early detection and management, especially in kids, are vital to prevent amblyopia and give the best chance for good binocular vision.
Spot on. Getting your head around the causes, the features, the investigations, and the management options is really key for your exams and practice.
Definitely. And if you want more resources for your MSRA prep, do check out pastthemsra.com and also freemsra.com. They're great sites.
Good plugs.
Thanks, everyone, for joining us on this deep dive into squints. Now, here's something to think about. Considering that potential psychological impact we touched on, how might outcomes change if we routinely integrated psychological support right from the start, alongside the eye patches and surgery for people with strabismus? Could that lead to better long-term well-being? Something to ponder. See you next time.